Okay, this talk is going to be covering Chapter 2 from the Professional Communication and Audiology book by Virginia Ramachandran and Brad Stach. This section is going to be Audiologist as a communicator, knowing your communication partner, again based on Chapter 2 in your textbook. So the first thing we need to do is make sure that the patient we call in the waiting room is the patient that we intend to see. That may seem pretty obvious, but you'd be surprised at how often mistakes can be made. And some of the reasons those mistakes can be made relate back to things that are specific to audiology and some of those that are more generalized to just healthcare in general. So for example, duplicate name, different date of birth. So say you have a very common name like Mike Jones or Tom Smith or something like that. Chances are you might have name duplicates in your list of clients just because the name is so common. So you want to make sure to check date of birth in particular, because when they have the same name, they will typically have different dates of birth. But another one that's a little more specific to audiology is because the people coming to see you typically have hearing problems, at least most of them typically have hearing problems. That means you might be calling a different patient, but they might think you called their name based on their expectation that they're going to be called. Maybe they weren't seeing you, maybe they're seeing your colleague, a different audiologist, and your appointments were at the exact same time. You're seeing a patient at 9 a.m., your colleague's seeing a patient at 9 a.m., you walk out to call your patient, and you have a new patient as well, and they start walking back towards you, and you greet them, and you start talking with them, and shortly thereafter you find out, oh, this isn't my patient. Their expectation combined with their hearing loss led to a receptive communication misunderstanding, and so that could have been avoided by confirming their date of birth or some other piece of pertinent information, the last four of their social security number, or whatever relevant information. So use two personal identifiers to confirm that you have the correct patient. The most common ones would be name and date of birth, but certainly there are other candidates for personal identifiers. Okay, then after you've called the patient back and you and your patient have been seated, the next thing that you need to do in the sequence would be to build rapport with that patient. I do want to define rapport. It's the dictionary definition is going to be a close or harmonious relationship in which people or groups concerned understand each other's feelings or ideas and communicate well. I want you to understand the definition of it because I don't want you to make the mistake of saying you want to develop a good rapport with a patient. A rapport inherently is good. Using the adjective good prior to rapport will make you look foolish in some situations, and your patients may be aware of the usage of that in some situations. So you're trying to establish or build a rapport, not a good rapport. All rapport is typically good. So you want to build this rapport is because your patient is your partner, essentially. Your partner in trying to improve minimize any negative impact of whatever the deficits are on their day-to-day life, right? It could be hearing loss, it could be tinnitus, it could be dizziness. Your goal and your patient's goal, your shared goal is to decrease the negative impact of whatever their complaint is. And so you're working together as a team. And so in a team, you want to have a positive working relationship so that you can be very effective and efficient and get the most done in the shortest amount of time. So you want to set the right tone, hit the ground running. You don't want to have any kind of negativity between you and your patient. So one of the first thing would be is you don't want to when you're first meeting the patient, you want to make a good impression. And so what you don't want to do is do anything to kind of irritate the patient or have them question your abilities in any way. And little things might kind of plant the seed for that sort of negative perception. Like, for example, if you call them Joe and they're much older than you, they may be fine with that, but that may bother them as well. It really is individualized. It will depend on the individual patient. So if when you're first meeting somebody, you probably want to use their formal name, Mr. So and so, Mrs. So and so. If you're not sure if the woman is married, for Mrs., you might say Ms. or Mrs. is probably okay. You probably want to avoid Miss unless unless you know the person isn't married. But also there might be certain titles, right? Because we are typically working with older clients most of the time, many times retired clients, but they may have certain honorifics that you want to utilize, like Dr. So-and-so. So it might be a professor, it might be a psychologist, it might be a physician. Doesn't matter if they're retired, it's something that you probably want to utilize if you have that information available to you. Clergy as well, so Father so-and-so, Reverend so-and-so, Sister so-and-so. It's just a title of respect. It has nothing to do with, whether they're in you believe in that particular religion. That's not the relevant part of it. It's about making sure that you're respectful to your patient. Now, if they tell you, you don't need to call me Dr. So-and-so or Mr. So-and-so, just call me Jim Bob, then feel free, call them Jim Bob. But you want to wait until they've offered that to you. You want to wait until they've suggested that it's okay for you to do. Pronunciation is another thing. Probably the way to make a good impression is not to walk out, call your patient, and butcher their name. So if you're not sure, you might ask a colleague, you might ask your front office staff. They may know this. What you could also do you could put it into Google and find out the most common pronunciation for the name, especially if the name is, say, from a language that you're less familiar with. So maybe Mandarin or Japanese or some language there or Farsi or something like that. Just some language you're unfamiliar with. If you don't know how to pronounce it, you might Google it if you don't have anybody else in the office who has a good guess at it. But if you don't know at all, feel free to ask. So one of the ones that when I was a student and I was working in a pharmacy, one of the ones that threw me off was Nguyen. So in Wichita, there's a fairly significant Vietnamese population, but I had no idea how to pronounce Nguyen, and that's pronounced Win. Well, I never would have guessed that. So someone else had told me that, and then I didn't have any problems with that down the road. So simply ask if your colleagues or anybody associated with you, if you're not sure, or ask the patient if in doubt. Also, feel free to Google it if you as a source of information. Nicknames should be discouraged. Regardless of the age and regardless of any differences in gender between the clinician and patient, probably you probably don't want to use sweetie or honey or anything like that. They can be demeaning in some cases. So you introduce yourself by your name and appropriate title. You might say, my name is Mark Shaver, and I'm the clinical audiologist here. You can call yourself Dr. So-and-so if you want. I'm not a big fan of that idea. Some people would advocate using it because to bolster any kind of, any confidence that the client has in you in terms of your abilities and your skill set and your knowledge base. I'm not a big fan of that personally. I think there's too much in the way of confusion with physicians, but feel free, if it's in your work environment and it's acceptable to do that, feel free to do whatever you see fit there. And then if you have anybody with you, whether it's any observers or audiology students, make sure to introduce them. You don't want random nameless people tagging along that might be kind of awkward and make your client feel a little uncomfortable. So make sure to introduce them, tell them who they are, why they're there. You may want to get permission as well from the patient to make sure it's okay with them to come along. The vast majority of the time it is, but I would not say 100% of the time. Sometimes you're going to have clients who may not be comfortable with a student coming along. If a patient is accompanied by others, and this is fairly often, if a patient is accompanied by, say, a spouse or a child or a friend, you want to kind of have a good understanding of what that dynamic is. In particular, you probably want to note down the names of those people that accompany them, because they might be coming back in the future with that patient. And note down, like I said, the relationships and of these people that attend their appointments. And so when these people come back for some kind of follow-up visit or some additional encounter in the future, and you have the name written down and you call their son or daughter by their correct name, they're going to be impressed that you remembered their name. It doesn't matter that you didn't really remember and that you wrote it down. It's still going to be, I would say it's still probably going to be a memorable thing for that family member of the client, in a memorable and a very positive way. It's a good idea to inform the patient what to expect during the appointment. If it's an evaluation appointment, you might give them an idea of how long everything is going to take, just kind of a very rough breakdown of the testing. We're going to test, see how well you hear tones. We're going to test to see how well you hear speech and quiet. We're going to test to see if there's any fluid behind your eardrum. Just however you want to do it, but you might give them some breakdown on what's going to go on in the appointment. And you also, there we go, duration of the appointment. Okay. And so to summarize all of the things I've mentioned so far is the AIDET strategy for patient encounters. You acknowledge the patient, you greet them. It's probably a good idea to shake their hand, make eye contact. Always smile, right? There's no reason not to smile. Smile large, make a good impression. Introduce yourself, tell them who you are, what your role is there. Say you work in an ENT office, you're there to evaluate their hearing before the ENT evaluates evaluates them to see if there's any medically or surgically treatable pathology. You want to let them know how long the appointment's going to take, right? Maybe they've got another doctor's appointment after that, and they kind of need to have an idea of how long it's going to take to see if there's any conflict, and then what to expect from the encounter. Is there anything going on going to be uncomfortable? Is there, if expectation, the lack of knowledge there in terms of expectation can make people, a little bit uneasy if they're not sure what to expect. I realize that with our audiology appointments, there's nothing really terribly negative to expect. But to think about it, what if you were doing a balance evaluation and performing some kind of calorics that were going to invoke some dizziness, and maybe the patient had some awareness of what this was based on what they read on the internet, based on what they heard from somebody else. Let them know kind of what's going on, and if there's any kind of unease, how can you alleviate that unease and comfort them? Then, of course, thank them for visiting, because thank them for choosing you in terms of your office, you as a professional, because they don't have to. Always remember that they could choose anybody else. So you're grateful that they were choosing your facility. You're grateful they were choosing you as a clinician, and you're grateful to be able to try to help them in any possible way. Make sure you're picking the right level of language to use with the client. What I mean is, so on the highest level would be, say, once you're an audiologist and you've graduated, on the highest level you might be thinking, how do I communicate with other audiologists or my professors or whoever, in terms of the words you choose, the jargon you utilize, versus how would you explain a hearing loss to, say you've got a 15-year-old nephew. How would you explain it to them? You're probably going to handle that in quite a different way when you have a conversation about hearing loss and dizziness and things like that. You want to be accurate if you're choosing a appropriate language level that's lower than kind of the highest, the default language that you would utilize. But you also want to make sure that you don't create any misunderstandings while you're trying to use more simplistic language. Actually, this is quite a talent to be able to do this. You'll find it can be somewhat challenging in the beginning, but you'll get much better at this over time. When you're talking with a client, trying to get the information that you want, but not using all the technical jargon that you've recently learned, right? And making sure to maintain a level of precision that you're looking for. Again, smile and shake hands where appropriate, right? I mean, there are going to be cases where it may not be appropriate. So if there's any cultural, religious differences, say, I'm not 100% sure if this is accurate, but maybe in more conservative Muslim faiths, maybe the woman wouldn't be comfortable shaking hands with a man, possibly. Hopefully I'm not terribly far off on that, but just as an example, there could be exceptions to that where it's not appropriate, but I think the vast majority of the time it's going to be appropriate. It's going to be something that you like to do. Now, I realize that shaking hands is probably a no-no in terms of infection control, but there's probably hand sanitizer everywhere you go in a hospital or ENT setting or most clinic settings. Smile, again, positive disposition is contagious, and it's good for you in general, too. It'll put you in a better mood if you're smiling all the time. Always remain calm and pleasant. I mean, this is even if you've got a very negative patient, or even, to go as far as to say if you've got a jerk of a patient, that can happen every once in a while. The last thing you want to do is respond in kind with that same negativity. You want to maintain your level of professionalism, kind of take the higher ground, always remain calm. Even if you're agitated, don't let it show. Be pleasant. And chances are that patient's negative disposition may improve over the course of the appointment. And even worst case scenario, if it doesn't, you've done your job. You've done what you should be doing. And then don't forget to build rapport with your pediatric patients. That may be a little bit different type of scenario because a lot of your communication is going on with the parent, but you need to build the rapport with the child. It might be talking with that child as though they are there, right? As not, you don't want them to feel like they're invisible, that you're only talking with their parent. You want to make sure that talk to them on a first name basis. You tell them, my name is Sarah, what's your name? And tell them what you're there for, comfort them, make sure that they are, that they're comfortable with everything you're doing. And then understanding your communicative partner. A communicative partner, of course, is your patient in this situation. You want to understand them in order so that you can most effectively apply your knowledge that you've accrued slowly over the course of your years as an audiology student, and apply your skill set, which you've honed over the course of your educational years, your formative years, and thereafter when you've graduated. You want to apply that knowledge and skill set, but to do that effectively, you need to understand where your patient's coming from. So you need to understand their linguistic and cultural background. The linguistic background, of course, is going to be very much in your face, in the sense that if they are not a fluent English speaker, you're going to become well aware of that, probably well aware of that. And you'll have to overcome that barrier. And then cultural background is secondary to that. Oftentimes they're associated with one another, but they're not mutually, they can be mutually exclusive. The person may have no linguistic difficulties, but the cultural background may influence how you need to engage with them. A good example would be, say, certain East Asian cultures, so maybe like Chinese or Japanese, Vietnamese, where they might view healthcare matters quite differently, and also the importance of family, and maybe Hispanic and Asian cultures as well, where you might be more likely to have family members there with you. Patients, another thing that might have an impact on how your communicative partner, your patient, is going to engage with you is their previous experiences with audiologists. Maybe they've had a great experience with an audiologist and they're very open and receptive to whatever you have to say. Maybe they've had a terrible experience with a previous audiologist and they don't trust you. And no matter how good of a first impression you've tried to make, they still may not trust you because they had such a negative experience with the previous audiologist. That's just something you have to accept and move forward with and try to change their mind about it. Not overtly, as much as simply basically adhering to best practices. You do the best you possibly can in terms of each and every part of the encounter, moving from the very beginning, like I said, where you call them, you greet them, you confirm you've got who you think you've got, you make sure you've said their name right, you go through your assessment after you've done the case history, and then you explain the results, and then you make sure that they have an understanding of it. You give them papers to take home with them. Any questions they have, you respond fully. So just basically adhering to best practices. That's the way that you improve the patient's experience. Even if they've had a bad experience with someone else in the past, it's your job to make sure they have the best experience they can possibly have. And then understanding your patient's communication abilities. So how does, for example, the hearing loss that they may have impact their day-to-day communication? Does that have an impact on their life from day to day? Or if they have a balance problem, does that impact their life on a day-to-day basis? What is the patient's lifestyle like? So are they a very active lifestyle, a very, very sedentary lifestyle? That's going to certainly play a role for balance, and it's certainly going to play a role for communication. The general rule of thumb is the more active someone is in terms of engaging in a variety of activities, probably the more people they're going to need to communicate with. And probably the greater the likelihood a balance problem affects their activities. So with communication abilities, for example, I'm going to talk more about hearing loss because it's more common, but also because I'm more comfortable with hearing loss than balance disorders. In terms of maladaptive strategies, that's another thing, is if the person does have a hearing loss that impacts their communication, they might gauge in certain maladaptive strategies. Some of these strategies might be bluffing, pretending like they know what's been said when they don't, or dominating a conversation, not letting you get a word in edgewise, which, if you recall, if someone is dominating the conversation with their own speaking and you cannot respond, that's not really an effective communication strategy, because you have one-way communication, not two-way communication, which is what you need in this type of encounter. And then understanding the presence of any cognitive impairments. So with older adults, we're thinking mild cognitive impairment or suspected Alzheimer's or dementia, dementia in general. You can also have dementia related to a variety of other neurologic disorders, such as Parkinson's and other things like that. We also can see cognitive impairment in persons who have strokes as well. So that's going to be a common, reasonably common type of thing that you encounter with older adults. So those cognitive impairments, so memory impairments, for example, might have an impact on what they can remember that you've told them, or it might have difficulty recalling certain events or problems in their life. They may misjudge certain things. So say, for example, someone is post-stroke and they tell you they don't have any problem, but their wife does, and they say, are you forgetting that this happened, honey, or something like that? So those can lead to inaccurate conveyance of information when you have cognitive impairments as well. So understand your communication partner to minimize any problems that arise from that. But each patient is unique, and so while most patients do want similar types of information following an encounter, for example, following an evaluation, they want you to interpret the results. They want you to give them a prognosis of their hearing abilities or difficulties for the future, recommendations on how to resolve any problems or treat any problems. And while we might use stereotypes to some extent to help us get a better idea of a patient, kind of a quick and dirty heuristic. If someone tells you a certain thing about themselves that causes you to subconsciously and quickly generate a stereotype, that's fine to some extent, as long as you don't let it guide all your decisions, and as long as you're open to letting that stereotype become personalized to the individual so that it's more accurate, right? We want to tailor the level of information presented to each patient. So we might have some patients come in that are on the one extreme, musicians, engineers, and physicians and scientists who are wanting a lot of detailed information, or they might have very specific questions, some of them which you may have never thought about and may have a tough time answering. And then you'll have other patients who come in and you're having to take the information that you want to present to them and use the appropriate language level and tailor it to them. Bring it down a few pegs in order for them to understand the information. So I thought about what to use as a contrast to engineer, and everything I could think of. I felt like someone could have a problem with this in terms of maybe it's not politically correct or something. So I thought high school dropout. Yes, of course you have high school dropouts who are very intelligent. And of course you can say, oh, people like Bill Gates, or, maybe he wasn't a high school dropout, but certainly you can name some people who became very famous and are brilliant who are high school dropouts. But if we look at people on average, engineer versus high school dropout, probably going to want a very different level of information. And ultimately, what they really want, patients want, yes, they want to have an understanding of the disease, but more importantly, they want to know, what do I do about it? What do I do to resolve it, or what do I do to minimize the problems? So what are some barriers to communication that we may encounter when we're talking with our patient? Well, the obvious one for us is, the hearing loss. We have so many patients. Most of our patients probably have hearing loss. So what do we do about that? Well, there's several things we can do. The one that you should probably get in the habit of doing almost all the time is modifying your speaking style by using what's called clear speech. The term clear speech is italicized here because it's not a generic term. It's a very specific term with a specific meaning. It is a speaking style that includes a variety of other styles, a few subtypes. You've got Lombard speech, which is the kind of speech we use when we're a very noisy restaurant, kind of like Texas Roadhouse. We also have infant-directed speech, so when we're talking like motherese, when we're talking to little babies. And then we have the hearing-impaired oriented speech, which is what we're talking about here. That's the type of clear speech that we're most interested in. And so just a few things that we typically do when we engage in clear speech. We typically use greater vocal effort, which produces a louder speech output. We typically use slower rate of speech, so we speak fewer words per minute, for example. We increase the number of pauses that we use in conversation. We increase the duration of each individual phoneme. So commonly you might say, we fully enunciate every speech sound. Chances are you can already do this without even thinking about it all that much. And a lot of times all someone has to do is ask you to, tell you they have hearing loss and to speak a little bit more clearly. And a lot of people can do this fairly intuitively, not all. And the exact ways in which this improves speech understanding are they're multifaceted. Things like having an impact on the vowel space, having an impact on the long-term average speech spectrum. I'm not going to go into all of those for now, but it is a very effective strategy. But it's not the only one. We have other things we can do to help as well. We've got simplifying your speaking style. So even if the person has the cognitive abilities and the wherewithal to understand the complexities of what you want to tell them at a very high level, if they have a hearing problem, that becomes irrelevant to some extent, because they can't, from the bottom up processing, they can't understand individual words or sentences. So you need to simplify your speaking style to reduce the length of your utterances and reduce the complexity of your utterances. Like things like, adverbs, you don't probably need any adverbs, or, limiting certain adjectives. You've got your subject and you've got your verb, and you want to just be simple and clear. You want to speak in the active voice, that kind of thing. You want to provide visual cues whenever you can. So basically, there should be appropriate lighting. Well, I take that back. Appropriate lighting maybe in an office space where you're talking to the patient, but if you're in a sound booth, you might have noticed the lighting can be kind of dim in there. So that can have a negative impact on their speech understanding for what you're saying, because visual cues can really, really help a lot, up to maybe 50% improvements in speech understanding by the patient watching your mouth, watching your face. But if there's not adequate lighting in there, especially with our older adults who have age-related vision issues as well, then it's less effective. If for for male audiologists probably get rid of that mustache. That's what I would say. Get rid of that mustache if you have one. Facial hair can have a negative impact on the ability for patients to utilize those visual cues so that they can improve their receptive communication abilities. So, sorry, no mustaches, no old-timey mustaches. All right, and then provide assistive listening devices. This is going to be one for people with severe hearing loss. You might have simply an assistive listening device, which is a small box that clips on the belt, connected to a pair of headphones, and it's just an amplifier. Heck, even if you don't have one of these in your office, it is so easy to make one. All you have to do is get yourself a pair of headphones for the patient, probably not earbuds because that's not super sanitary, but a pair of headphones, and you plug it into a phone. Your phone, their phone, a spare phone, you just download an app, and you can typically turn it into an assistive listening device if needed. Interpreters, and this gets a little bit sticky here, but sign interpreters. If the person, say their hearing loss is congenital, and they went to the school for the deaf when they were younger, and they're fluent in American Sign Language, and they only use a hearing aid, say, as an aid to speech reading or lip reading, that you may need to provide an interpreter. It is actually the patient's right to have that interpreter. It is not something that you're doing out of the goodness of your heart. Although you certainly, I'm not saying you wouldn't do it out of the goodness of your heart. I'm saying you need to do it by a law. That's kind of what I'm getting at. And for patient outcomes too, because patient outcomes are going to be improved when communication is occurring in their native language. And then where all else fails, I've had to resort to a pen and paper. And usually when I've had to resort to this, it's because with patients with profound hearing loss where they needed that interpreter, they didn't give us any advance notice they needed an interpreter. And in some facilities, you can't just go and boom, an interpreter appears. Unfortunately, it doesn't work that way. So pen and paper, there could be also texting devices, one-on-one messaging. I was debating whether or not just you use your cell phone, they use yours. I mean, that's far more efficient than texting. I don't know from a professional perspective if it's super appropriate or not, but I personally wouldn't have a problem with it. I think that'd be a very effective way to do it because I would say many deaf and hard of hearing persons are going to heavily rely on texting. And then this kind of ties back in with what I mentioned a moment ago with American Sign Language, but now I'm talking a little bit more about people who are speaking, say, Spanish or Mandarin or Russian or whatever, communicating their language. Again, they have a right to have the encounter occur in their language if they are not fluent in English. Because miscommunication, it's part of the Civil Rights Act actually, because that miscommunication that may occur when they're speaking in a foreign language may reduce patient outcomes, and that's been shown in other non-audiology fields. So communicating in the patient's language is protected under federal law, and you have to foot the bill for it. I hate to tell you that for any potential private practice owners, you have to pay for that. There is no funding from the American Disabilities Act or Civil Rights Act or anything like that. You have to pay for it. So sorry. And there typically are better outcomes on average for professional interpreters, not ad hoc interpreters. I know it's tempting to use a family member there who might speak a child or a spouse who speaks language, but it's not considered appropriate. And I think there's been some recent legislation changes that have made this very improper. So professional interpreters are what you need. Interpreting is a skill set in and of its own. So it's not like, say for example, you know somebody who's fluent in English and Spanish. Well, this person is not automatically a professional interpreter. There is skill involved in being able to change from one language to another without superimposing little modifications to what's been originally spoken. And when you're talking to a patient who speaks another language, it's important that you look at that patient. You don't look at the interpreter. You're communicating directly with that patient. They are your patient. The interpreter is there just to convert from one language to another, but they are not there to superimpose any opinions or any color into what's being spoken. So here are some tips for speaking to patients with language interpreters. Although keep sentences short. I mean, it is more cumbersome. It is clearly more cumbersome when there's an interpreter there, but it is still considered the best way to handle things. So keep sentences short. Use simple language. So some of these things I already talked about in terms of choosing the appropriate language level for the client, or when I'm talking about speaking to persons with severe hearing loss. Some of these things are similar, but for different reasons. Avoid asking more than one question at a time, because that can be, then you start taxing the interpreter's working memory. Then it gets confusing for the patient really quickly. Maybe they're responding to a different question than one you asked before. Take it slow, one at a time. Keep it simple. Avoid any slang or any technical jargon. There's going to be a lot of pauses in there in general, and yeah, of course, you need to document the presence of that interpreter in the medical record. Other concerns I haven't addressed as much: cognitive, speech and language concerns, etc. Anytime there's difficulty providing or receiving information, that's going to fall under this communication barriers. So some common examples would be very young children with speech production deficits, maybe because of hearing loss, maybe because of unknown reasons. But if they're producing, if they have any deficits there, of course that's going to be an issue. Patients with cognitive impairments, they could be traumatic brain injury, it could be aphasia, it could be dementia, you name it. For these patients, you want to do the best you can to modify your output, your language, your speech, to simplify and abbreviate any explanations, any recommendations, because the message is what you're trying to get across. The nuance is less important than the fundamental message. The nuance is great to add if you can, and that might be more with, for people who have a high level of education, high level of communication abilities, without any deficits getting in the way of understanding. But you need to get across the fundamentals at the bare minimum. Then we also have time constraints. This is the one that I battle with constantly. I am terrible at managing time with patients, although I think I've gotten a little bit better over time. And one of the reasons it can be a challenge is because I found an unusually high number of my patients will talk excessively. Now, why they do this can be for different reasons. There can be very legitimate reasons for their excessive communication. It can be there's been a lot of stuff going on, and this isn't the norm. This is probably more common in an ENT medical setting, where they have this really crazy, bizarre, interesting history related to their hearing loss. Maybe their Meniere's disease, maybe related to sudden onset hearing loss, maybe related to ototoxicity. But there may be a long history for that reason, and that's okay. That I don't have a problem with, because you're getting to the root of why they're there. It's an integral part of the patient encounter. But sometimes that patient is engaging in a maladaptive communication strategy because they have hearing loss. They may dominate the conversation. This really reminds me, and I don't mean to get too personal with you, but I mean it does remind me of a situation that really kind of hit it home for me. Maybe, I don't know how long ago this was, but I'm going to say maybe 10, 12 years ago. I was dating a girl who happened to have severe to profound hearing loss. She wore hearing aids. She fluent in signing, and she, was very oral. She was really pretty good at oral communication, and but she would just kind of dominate the conversation. And at first, I think I was an audiology student at the time, and actually I know I was. At first, I thought this was just kind of her personality. I think we all know people who are just kind of very very talkative, let's say, and they kind of have a tendency to dominate the conversation in general, and sometimes, it might be a little irritating, and I just thought that was part of her personality. But I remember going through my audiology courses, and in one of my courses around the same time, I remember learning this, and I had no idea in the beginning that this might just be a maladaptive communication strategy, where if they don't understand, what's being said, a certain highish percentage of the time, they may, rather than not understand what's being said, they may just dominate the conversation because they're not misunderstanding what they're saying. But again, it's a maladaptive strategy. It's not great for two-way communication. And so in those situations, the authors of the chapter give a kind of suggestions on how to handle it, outlining to the patient what needs to be done during the visit so they understand that maybe there's a lot more that needs to be done. If they have some expectation in the beginning of how long that appointment should be, they might kind of have an idea of those time constraints. I'm not probably the best one to ask for this because I struggle with it sometimes. But sometimes I'll, once they've gotten to the end of a section of their story, I try to shift gears and move that conversation in the direction that I want it to go to finish up that encounter. Okay, well that finishes up that section on the audiologist as a communicator. You can see here the next section is audiologist as a detective, gathering evidence, and so I'll have that up here in the weeks to come.